Hi, now I'd like to talk to you about a certain aspect of the antibiotic stewardship initiative that I find more disturbing even than the other areas I discovered with regards to how Lyme patients are being restricted from federally sanctioned treatment options through the antibiotic stewardship initiative. This is with regards to the native lands and 1.5 million American Indians and Alaska Natives, of 557 federally recognized tribes through a network of 37 hospitals, 60 health centers, 3 school health centers, 46 health stations, and 34 Indian health centers. Basically, the Health and Human Services provides health care to this population through the Indian Health Service. And the Indian Health Service is using pharmacists as primary health care providers under the stewardship program. It's called IHS, Indian Health Services. I'm going to describe the situation to you a little bit more. Okay, now the National Pharmacy Council Antibiotic Stewardship Program, ASP, for ambulatory care is being implemented by the IHS pharmacists, and they focus on specific infections. These are where the guidelines say specifically what you are to give to for these kinds of illnesses. They include dental infections, skin infections, urinary tract infections, sexually transmitted diseases, and upper respiratory infections. There's also tuberculosis, Helicobacter pylori for ulcers. And then there's one sole vector-borne disease that's listed in this guidelines, and that is Lyme disease. Anyway, Lyme is the only vector-borne disease listed in the guidelines under the IHS, and this is very interesting because Native American lands have many other vector-borne diseases, including Rocky Mountain spotted fever and West Nile virus. Within this compendium or the guidelines on treatment options, all the diseases listed have a number of references that make up the body of the treatment options, why these treatment options are available, and you actually have choices between them, and there are many different reference sources. However, Lyme disease has one sole reference, and that reference is the IDSA Lyme guidelines, which, as we know, are non-compliant, substandard, and outdated. Why did this happen? Well, there's a particular actor involved with this, perhaps, most probably. This actor has worked for the CDC, has worked on the, co-authored the antibiotic stewardship with the IDSA, their guidelines, is a consultant to the Indian Health Services, is a member of the Antimicrobial Resistance Working Group, President's Council of Advisors on Science and Technology, created, manages, and leads the California Antimicrobial Stewardship Program Initiative. California is the first and remains the only state to enact antimicrobial stewardship legislation. And basically, altogether, this actor is placed to create circumstances that have combined to place Native Americans who contract Lyme disease and co-infectors in harm's way. Basically, what they have done is they've used the IHS to institutionalize discrimination against Lyme patients now in Native American lands. So it's now been extended specifically into Native American lands. This is very disturbing. This group is already so vulnerable and underrepresented in many, many ways in terms of numerous concerns. So I just want to talk a little bit about the Universal Declaration of Human Rights, because so much of what's going on is not only against federal statutes and against federal laws and against good common sense and against ethical and moral concerns and compasses, but it involves the Universal Declaration of Human Rights. I'm going to talk about a number of different articles that show just how Lyme patients are discriminated against. Article number 5, no one shall be subjected to cruel or degrading treatment. Being given a treatment option that is outdated and non-compliant to federal advisory bodies and independent bodies is a cruel and degrading treatment. Not only that, oftentimes Lyme patients are told that they have a mental illness, a somatic disorder known as medically unexplained symptoms, MUS. And this mental illness is called an overreaction to pain, irregular heartbeats, neurological twitches and tics, shortness of breath, and organ malfunctions, and all the myriad of symptoms that happen with chronic Lyme and systemic Lyme. To be told that you have a mental illness when you have these symptoms is a cruel and degrading treatment. Number 2, all persons have the right to equal access to public service. Clearly in this case, the public mandate for health care protection for the public, the Lyme patient, does not matter. Article 25, all have the right to medical care and security in the event of unemployment, sickness, and disability. Well, of course, in this situation, many thousands of people are becoming disabled by Lyme. They, in this case, can't even access disability insurance because they're told they don't have Lyme and that this is simply a mental disorder perhaps, and they're being denied care that is sanctioned by the National Guidelines Clearinghouse. So you're getting disabled by Lyme, you're not getting disability insurance coverage, you're not getting medical care even when you are disabled, even though you're already part of a vulnerable group. You're losing your employment because of Lyme, and of course there's the sickness involved in general that comes and goes. Mother and children have special considerations under Article 25 of the Universal Declaration of Human Rights, and children are at particular risk for Lyme, and they are not given treatment options. So this is another violation. Article 27, all have the right to share and participate in scientific advancement and its benefits. Well, we have the NIH sponsoring articles that say Lyme patients are not to share and benefit in science and advancement. They're not to consult with Lyme scientists. In fact, we have been excluded very extensively. The good science that does exist, of which there's quite a bit of advancement in Lyme, understanding of co-infections, alternative ways in which to diagnose Lyme disease, as well as treatment options that do in fact improve people's lives and quality of lives and reduce their symptoms. These things have been denied, and therefore in that way we are not sharing in scientific advancement and its benefits, particularly its benefits, are being excluded from us. Article 30 is that no state, group, or person has a privilege to destroy these rights. Well, in fact, these rights are being destroyed. They are being disrupted, and they are being taken away. Every day the CDC promotes these guidelines and the 2-tier testing that are out of date and non-compliant. Okay. I just want to come to conclusions and recommendations. I know this is a very long and detailed and probably dry presentation, but it is very complex, and that's why I felt I needed to share all of these details. Basically, a group of IDSA members have used their power and connections to institutionalize far-reaching discrimination against Lyme patients. It is reasonable to assume the IDSA will exploit any opportunity to deny Lyme patients access to non-IDSA treatment outcomes. For example, there are 44 states that have legislation in place that can potentially use pharmacists as primary health care practitioners outside of the Native American lands. And it is reasonable to assume that the IDSA will attempt to harness the Antibiotic Stewardship Initiative and the National Pharmacy Network to implement their substandard guidelines, as they have the Indian Health Service Pharmacy Network. I mean, why improve your guidelines if you could just codify them into law and regulations under the Antibiotic Stewardship Initiative? Furthermore, there are 10 states that are designated as the Centers for Disease Control and Prevention Emerging Infections Program, EIP. And the EIP states fast-track all infectious disease policies. And Lyme is one of the infectious diseases studied by EIP states. and they are California, Colorado, New Mexico, Georgia, Maryland, Minnesota, New York, Connecticut through the Yale EIP program, Oregon, and Tennessee. The Oregon head of the ID policy is an IDSA member. He has used the non-compliant guidelines to reframe Lyme disease to an even stricter definition than what it is currently in the guidelines, which means even fewer Lyme patients will be diagnosed and treated. Given this case in Oregon, one must assume it's happening in all the other 10 states where IDSA has a clear presence in the EIP programs. IDSA political influence has escalated due to global changes, concerns for epidemics, pandemics and bioterrorism, and partnership with Big Pharma. Antibiotic stewardship gives the IDSA a global platform to promote their substandard and federally non-compliant Lyme guidelines. The CDC and NIH appear willing collaborators and enablers of this very intrusive overreach. CDC directors responsible for the Lyme policy and programs are all IDSA members. All aspects of these programs and policies are therefore very compromised. The promotion of non-compliant medical guidelines for Native Americans shows poor judgment on many different levels, and the political optics alone are simply stunning. So let's just get to some conclusions and final recommendations. Basically, as a result of the relationship with the IDSA, the CDC routinely violates federal laws, disregards congressional directives related to appropriations bills, and ignores and undermines state laws that are there to protect constituents, and particularly Lyme patients. Number two, it's promoting policies and programs that are non-compliant to other health and human services agencies and advisory institutions. Three, it is misinforming the public as to the complexity of the illness and its potential for disability and death. It is generating ill-conceived programs that do not meet their own strategic objectives. It ignores or discredits groundbreaking Lyme research accomplished by non-IDSA scientists and medical practitioners. It fails to advance any patient-centered outcomes. And it discriminates against Lyme patients who are disabled, Lyme patients who are female, because the two-tiered testing is particularly insensitive to females, even more so than males, as much as 60% insensitive for females. And Native Americans, another vulnerable group. And of course, all those people who do not have the personal financial resources to pay for care outside of their insurance policy. That means people who cannot go to a Lyme literate doctor and pay out of pocket for extended treatment, as sanctioned by the National Guidelines Clearinghouse, GRADE, Institute of Medicine, etc. The global Lyme community well knows that the CDC is proposing and promoting federally non-compliant IDSA Lyme guidelines throughout the world. It's well known. This information presented today will be shared worldwide with the global Lyme community. And I'm going to end with some recommendations. Remove all reference to the substandard and federally non-compliant IDSA Lyme guidelines throughout the 50 states and protectorates, the CDC global dissemination, and the Native American lands. Only incorporate federally sanctioned, evidence-based, patient-centered Lyme guidelines. And omit the two-tiered testing and use clinically based diagnosis, because it is far more accurate than the two-tiered testing, until we have a diagnostic tool that is better for testing Lyme presence. Place a qualified nominee from the Lyme community as a voting member on the antimicrobial resistance working group on the President's Council of Advisors on Science and Technology. place qualified nominees from the Lyme community as voting members on committees that inform the Health Evidence Review Commissioners in all 10 of the Emerging Infections Program designated states. 4, make official amends to all countries that adopted the IDSA Lyme guidelines according to the recommendations of the U.S. government and the CDC. And with that, I would like to close, and I hope that this informed you and helped you to understand why we are in such a mess and why so many people are getting sick and disabled from Lyme disease in the U.S. and many other parts of the world. Thank you very much.